Good afternoon, good evening, and good morning to everyone. Have a good day. Who are joining, I can see from around the world, and especially to my friends in South Asia. Today we are here for the second regional webinar, actually, by WONCA Special Interest Group on Policy Advocacy. We had a previous webinar from the regions in WONCA Ibero-Americana region, and this is the second one in South Asia. Today, our webinar's topic or the theme is advocating for family medicine education. And we have three pioneers of education with us from three countries of South Asia, India, Pakistan, and Sri Lanka. While welcoming you all, my colleagues and the speakers, including one of my teachers, or the one I consider as my family medicine guru, Professor Antoinette Perera, Professor Waris Qidwai from Pakistan, and Dr. Raman Kumar from India. I would like to introduce my co-chair or the co-moderator, that is Dr. Pramen Prasad Gupta from Nepal, who is also WONCA South Asia Regional President-elect, who's joining with us. Thank you, Pramen, for joining today.
Thank you, Sankha, for inviting me.
Our WONCA Special Interest Group on Policy Advocacy's co-chair, my co-chair, Professor Amanda Howe, had sent her greetings to us. Unfortunately, she's not joining us today due to some personal matter and the time difference. The UK, it has been a bit difficult to her to join. Let me first show a video, and then let's go ahead with the webinar. Here we go.
Dear colleagues, I wish you well for the Family Medicine Education webinar today. I'm very sorry I can't join you in person, but I have some family commitments here. As some of you will know, almost my whole career has been dedicated to trying to improve medical student and medical postgraduate training by giving people the placement in community and family medicine. And the reason is, of course, not only to promote our specialty, but to give them real insight into people and people's lives and people's health, acute conditions, chronic conditions, ongoing challenges, lifestyle. They don't see that in hospital. They don't see it in a laboratory. And so it's really important to champion the opportunity to bring students and trainees from all specialties out into community settings where they can get those experiences. And it often also helps them to feel validated as people, as doctors, when the community are interested in them and want to help them with their training. So I really look forward to the webinar, and I will watch the recording afterwards. And I thank you very, very much for your work in your region. And I wish you well for today. Thank you for asking me to contribute.
After this beautiful video of Amanda with her message, I'd like to thank her for her message. And I'd like to welcome everybody in this webinar. Now we are moving on to our presentations. So I'd like to invite our first speaker, Dr. Raman Kumar, who is past president of WONCA South Asia. He is chairman Emeritus, Academy of Family Physicians of India. He is convener, specialist board in family medicine, National Board of Examination in Medical Sciences, New Delhi, and he is a full-time family medicine practitioner. So Dr. Raman, please.
Thank you, Dr. Pramen and Dr. Sankha. Can you hear me?
Yes,
Okay, yeah. Thank you. So please share my slides, please. I'm traveling, so a bit maybe connectivity issue, but I try my best to cover it as fast as possible. And thank you to WONCA SIG on advocacy and policy for hosting this very important webinar, which is important for not only for South Asia, but for
Thank you, Raman.
I've seen
can we go
different
ahead?
parts of the world. Yes, thank you. And so I'll be talking about our experience from India, from advocacy to act, how we started as an organization, change, modify the Act of Parliament, which deals with the medical education, and family medicine was specifically included, the Act of Parliament, which is called National Medical Commission Act 2019. So these are my affiliations. We move forward. Academy of Family Physicians of India, I've been introduced already. Sankha, next slide, please. Next slide, please. So, we have experience of around 15 years how to advocate family medicine in different countries, different parts of the world. And from that experience, from our study or our journey, to me, it appears that the status of the specialty depends on the economic status of the country, political economy, and how healthcare delivery system is designed, public versus private. And these are the important factors that determine the status of family medicine in any country. Next slide. Sankha, next slide, please. Full पे आ गए क्या? Connectivity.
Can you see the slide, Raman?
Yes, sure. Thank you. I can see
Go
that
ahead.
now. So, a lot of it depends on every country's health policy, public health system, and how public health system looks at the comprehensive primary care component or primary care component. And many parts of the world, like in our region, it is largely selective primary care, which is integral part of public health policy. So if you see the difference between comprehensive primary care and selective primary care, mostly in the selective primary care countries like ours in South Asia, we have established our health system based on the vertical programs, disease-based. Sankha, I can't see my slides now. Thank you. Can you move forward, please, again? Yeah. So the design of the public health system and how the system is designed to address primary care, whether it is comprehensive primary care or selective primary care, is one of the most important determinants of status of family medicine. Because family medicine is comprehensive clinical care in the community, which is largely overlooked in the selective primary care system, where we have disease-based national programs, as we see in our countries of South Asia. So it was a challenge in our country to challenge the design of public health system, which also affects the medical education system largely, because in medical education also, we did not have this public health and family medicine component. And it was all community medicine, which was not largely addressing the needs of the educational aspirations or needs of the community-based primary care, which is family medicine globally as understood. So we wanted to challenge this in a way that we move forward and it is integrated into the mainstream medical education system. Next slide, please. Sankha, next. Can you hear me?
Yes, we can hear you, and I have moved to the next slide if you can see it.
Okay.
Yeah.
So the most important thing to have an organization in any country which is spearheading or kind of an advocate or voice of family physicians, family medicine, family doctors, or family medicine specialists. So we did have organizations in India, but somehow the development was very slow in past few decades. And these advocacy events and conferences, which were focused on the academic needs of family medicine, were required, which were not happening because it was all specialist training GPs model that were happening in India. And we did not have enough scholarship base in terms of scientific publication, which would give any policy impetus or direction to our policymakers. And we looked at in our literature review, and when we were trying to determine our strategy, and largely there were many reports and recommendations of government which were not being implemented, not being recognized for policy implementation. They were written the policy documents, but they were not implemented practically. And we understood that it is important that we were only a part of the health system, and we had to engage and encourage all stakeholders, including the healthcare industry, the specialties, the medical education regulators. And we also thought of legal options that were available. And we also took the legislative action, which was through our political representatives. And I will briefly share the journey as we move forward. And advocacy is a continuous process. It is not a one-day thing or a one-year thing. And what we have achieved in 10 years was achieved over a period of decade. So it is a continuous process, and it is a work in progress, and we have to keep on moving on this pathway of advocacy and policy development, because the ideal situation that we all want will evolve when we keep on pushing for it for a long time, or for a continuous longer duration of period. Next slide, please. So in this background, I would like to acknowledge the role of Dr. Prakash Chand Batla, whom we consider the father of family medicine in India. And he was not only founder of Indian Academy, IMA CGP, which is Indian Medical Association College of General Practice. He was also integral part of the development of WONCA, World Organization of Family Doctors. So on his seminal work, his initial foundational work, we developed our strategy, and we are working still on what the foundation he laid down, and in during time. Sorry. Next slide, please. So Dr. Prakash Chandra Batla, with his colleagues, in his time in 50s, 60s, and 70s, established Indian Medical College of General Practitioners, which was established in 1963. It was same time when the discussion of WONCA started, that we should need a WONCA, World Organization of Family Doctors. Next slide, please. And you can see Dr. Batla in the inaugural meeting of WONCA in Melbourne. Next slide, please. And afterwards, we, as in the introduction itself, I was introduced as Chairman Emeritus of Academy of Family Physicians of India. This is relatively a new organization, and we wanted to establish and integrate family medicine with the mainstream education system, and it was founded in 2010. And since then, we have engaged with WONCA, and it is part and parcel of our advocacy process. And whenever we do any conference, any events or workshops, we involve WONCA experts, and we try to bring the international best practices when we talk and advocate for family medicine and policy integration in India. Next slide. Next slide, please, Sankha. So this is a brief history. There were some initial reports, one which is called Bore Committee Report 1948, which talked about comprehensive primary care. And the regulator of medical education was established in 1956, Medical Council of India, which defined the basic medical graduation course, MBBS. And then we had this Mehta Committee report in 1983, which talked about sending the students to community-based general practice units. And again, in National Health Policy 2002, it was commitment that at least 25% of our medical graduates should go into the specialty of family medicine. That did not happen. But in again, 2005, we had a big reform in our national system of healthcare delivery, which is called National Rural Health Mission. And in the documents of this National Rural Health Mission and its program, it was felt necessary that we need human resource which is generalist in nature and is able to provide broad range of services in community. And family medicine fitted this requirement of the public health system. And this was again emphasized in National Rural Health Mission in 2005 documents. Next slide, please. And 2010, we founded Academy of Family Physicians of India. And in the same year, we had a meeting with high-level stakeholders, Ministry of Health, regulators of medical education, other medical institutions. And it was the first high-level meeting which was initiated at the request of Academy of Family Physicians of India. 2010, again, we had opportunity to meet in WONCA, South Asia, and see our South Asian colleagues in WONCA, South Asia regional meeting in Kathmandu, and we were able to see how the specialty was developing in Pakistan, Sri Lanka, Nepal, and it was very inspiring to see that family medicine was taking footholds in South Asian countries. And we took inspiration from this meeting. 2011, we had our first Spice Route conference. We founded Spice Route in WONCA, Kathmandu, 2010. And this was held in Mumbai, India. And again, we had a large number of WONCA delegates and WONCA leaders hosted in Mumbai, India, which was again a kind of advocacy event as well as development of a specialty event. In 2013, we hold our first National Conference of Family Medicine and Primary Care. And we had also a consultation, high-level consultation meeting with Ministry of Health. And it was in regards to the National Rural Health Mission, because India largely 60% is rural population, rural communities. And to address the general medical needs or community-based public health needs, it was important that we strengthen the process of family medicine. And we emphasize and we worked with the Government of India, Ministry of Health. And this was through this advocacy events, we were able to build up a background for development of family medicine in India. Next slide, please. So this is our organization, which is dedicated to Academy of Family Physicians of India. And you can see the 9 rings, the 9 principles of family medicine. And the idea was to strengthen the academics. Earlier, we had associations, and associations were becoming largely political organizations, and focus was less on the academic development of family medicine. We were focused on developing the academics of family medicine in India. Next slide, Sankha, next. And at this meeting, you can see Professor Michael Kidd, then President-elect of WONCA. He came to our conference. And on the top right, you see the Secretary Health, Government of India. So we try to bring experts from all over the world, from Brazil, from Southeast Asia, from Europe, from Australia, from WONCA. And we also brought all stakeholders from different parts of India and different organizations of India to discuss about the specialty of family medicine. Next slide. So you can see Professor Michael Kidd and other important organizations being represented at this first meeting, which was 50% advocacy and 50% clinical training or the academic needs of the family medicine experts that we thought of. So every meeting we do 50% advocacy sessions and 50% is focused on the clinical or CPD events or CPD sessions. Next slide, please. And this was the national consultation on family medicine in partnership with National Rural Health Mission. And we published a report. Next slide. And then we were part of the WONCA South Asia Chennai meeting 2014, and which was again attended by the world leaders of family medicine and different stakeholders of family medicine. It was in partnership with Indian Medical Association College of General Practice. Next. And here you can see while we were doing these events, we were trying to meet the highest level of political leaders. So you can see we met our health minister, and he is also currently the president of the largest political party in India. And at that time, he was health minister. We invited him to our conference, and it influenced the national health policy for our country in 2017. Next slide, please. So you can see in policy development and advocacy. And he came to our national conference, and that was a very influential moment on national health policy, because after 2 years of this event, our new national health policy was declared, and in that policy document, we had family medicine retained as an important focus area of family medicine. Next slide, please. And recently, we continue to meet our other stakeholders, and we met the chairperson of the National Medical Commission, which is the principal regulator of medical education. Next slide, please. And we also engage with community, and we invite community icons. Next slide. You can see Mr. Milkha Singh, the Olympian, whom we invited to our conference. And the idea was to engage community, and we launched a campaign which is called Run for Family Health, physical activity for all family members. So the idea was to engage community at the same time as part of the advocacy process, so that the community also understands the importance of family medicine. Next slide, please. Next slide again. And in the same process, as we move forward in the future years, in 2018, we organized the WONCA World Rural Health Conference in India, which was again, we had delegates from 40 countries from all over the world. And it was again a very big push to family medicine advocacy, apart from the educational opportunity that we organized for the family medicine experts, delegates, residents, students. Next slide. And in every meeting, we engage with the political leaders, bureaucrats, policy makers, stakeholders, and we had our vice president, who was also the chairperson of the upper house of the parliament, who inaugurated this meeting. He spoke at this meeting. We had the health minister and the director of the National Health Mission, who all participated and spoke at this event. And this is how the momentum for family medicine grew forward. Next slide, please. And this was the report. So creating documents, reports, advocacy tools during these conferences is important to move forward. And this helps in disseminating to different stakeholders or policy makers, because India is a large political democratic country. And we have to keep on involving stakeholders and producing documents which, kind of become evidence or kind of a democratic voice for aspirations of community as well as that of family medicine academic persons. Next slide, please. And you can see the two reports which we have produced in past few years, sorry. Next slide, please. And our idea was to produce large number of leaders. So we ran a campaign which is called 100 Faces of Family Medicine, and you can see 100 faces. And today we have membership base across India, all states of India. We have state chapters, and we have tried to develop young leaders who are taking forward family medicine academics in India. Next slide. Research and publication is very, very important, position papers. And we have published more than 400 papers on family medicine since we started. And these papers function as important referencing documents when we, visit or write to our stakeholders. Next slide, please. So we also focus on the clinical practice, evolving standards. Next slide. Accreditation. Next slide. Standards. And while we are doing these conferences and events, we are focusing on these important aspects of clinical practice so that we evolve, raise the standards of family medicine in India. And these are the recent changes. 2021, we had this new curriculum which was entirely written by family medicine experts. So as convener of the Specialist Board of Family Medicine at National Board of Examination, I along with other colleagues, we wrote down the new curriculum of family medicine, which is now clearly states what is the distinction of family medicine, what family medicine it is, and now we also have positions for family medicine postgraduates in public health system, which was not there earlier. So this is again due to the advocacy impact that we were doing over a period of 1 decade. And whatever recruitments, resource allotment, allocation is done is based on the Indian Public Health Standards guidelines. And the older one version was released in 2012, which did not mention family medicine anywhere. But because of this continuous efforts, advocacy, we were able to make changes in IPHS guidelines, which was released in 2020. And now the revised guidelines include family medicine positions in India in the public health sector. And we had this FMPC, we continuously are having this national conferences where we engage stakeholders. We also, and as a purpose of advocacy, we also celebrate National Family Medicine Day as foundation day of our organization to emphasize the role of and importance of family medicine in India. And recently, when we organized our first National Family Medicine Day, we also organized a national consultation on undergraduate family medicine in India. Next slide. So you can see National Family Medicine Day is celebrated as AFPI Foundation Day. Next slide. And this is all part of the advocacy process. And when this was launched, we again invited the high level stakeholders and policy makers of our country, the research domain, the education domain, the service domain, the medical education domain. All were invited for this event so that they are all aware of the process that is being being raised in the democratic aspirations of our country. Next slide. So in this, as I talked about the legislative process, we can write to the Prime Minister of India, and we wrote to Prime Minister of India 18, raising that this was an important area which was being and in spite of being written in policy documents several times, it was not being implemented. So we got a reply from the Prime Minister of India's office, which assured that whenever this new act of comes, it will be adequately addressed. Next slide, please. So this was the National Medical Commission Act, which was passed in the Parliament of India, and at least 4 or 5 sections of this act. This is now Act of Parliament. There is a difference in policy binding on the government. The policy is the aspiration of the government, which is there no binding. You cannot go to the court or the legal platforms to address if something in the policy which is not implemented. But if it is an act, if it is not implemented, you can go to the court, you can challenge it legally. So this was a great achievement for a part of our advocacy because we were able to manage family medicine through an act of parliament, which was very, very unique in any part of the world. And only family medicine has been mentioned in this act. Other specialties, of course, they are important, but it was put into the act because it was thought by the Parliament of India that it is important to emphasize this domain of medical specialties. Next slide, please.
Raman, we can't hear you.
This is our new parliament.
Raman, your voice is breaking.
Please.
Yeah, your voice is breaking. Yeah, we didn't hear.
Okay,
you
there's
before.
activity issue here. It will remain
Yeah,
so for few
now
seconds.
we can hear you. Go ahead.
Next slide, please. Okay. So this is the new Parliament of India. As you can see, democracy is evolving. So is family medicine evolving in India. Next slide, please. Next slide, please. Can you change it, please? Yes. And we, which is Niti Aayog or Policy Commission, through which we do a lot of advocacy, and we were trying to emphasize the Policy Commission of India to integrate family medicine in the health system delivery, the system of the healthcare delivery system of India. And we have been successful in modifying several of the bottlenecks of family medicine development in India through Policy Commission, through engagement with the Niti Aayog. Next slide, please. And this is the Indian Public Health Standards, which I talked about earlier. And this includes family medicine positions in the public health system. Uttar Pradesh government is the first state in India to include family medicine at a specialist post. And they have recruited 2 batches of specialists in the public health system of India. Next slide, please. Sankha, next. Now, this is about the universal health coverage module, which is called Ayushman Bharat program. And in this program, it is integral that family medicine come up as a very important component. And this includes 2 parts. One is, the insurance part of the national health system. So firstly, they have tried to cover around 40% of the poor population of India in the Ayushman Bharat program. And currently, it covers only the hospitalization. But India is a large important that we have some gatekeeping clinical services in the community. Without that, this financial tool will fail. And this our policymakers understand. So they are moving forward with this program. Digitalization of healthcare is very, very important. Each Indian citizen is being now given a number which is called Aadhaar card. Next slide, please. Which is Aadhaar number, which is a digital health ID of Indian citizens in India. Next slide, please. And for this purpose, we have created National Health Authority, which is an oversighting body of implementation of Ayushman Bharat program in India. Next slide, please. Next slide. Next slide, please. These are the important things, but I will cover because time is short. I've talked about them already. And many of the medical colleges in India have started, for example, all new aims of Department of Community Medicine and Family Medicine. And this was introduced way back in 2006. And then it evolved. And now recently, this is the most recent document. And we are trying to integrate into the undergraduate family medicine component into the MBBS curriculum of India. And we are the largest medical education system in the world. We have 700 medical schools across India with a capacity of more than 100,000 MBBS seats. And we are emphasizing with the government that at least 25% of the postgraduate seats should be converted into family medicine. And all tertiary large models of medical education, which are called All India Institute of Medical Sciences India, have Department of Family Medicine and Community Medicine. Next slide. This one is the final slide. And this is the recent document released by the Health Minister of India. And this is by the Undergraduate Medical Education Board of the National Medical Commission. And you can see at the top of it, making of a family physician. So finally, we have been able to, knock at the right doors, and they're trying through the national health policy as well as in the medical education mainstreaming to change the curriculum, to change the medical education system, to change the career pathways of the medical graduates, to integrate them into the healthcare system of India. And this is how we have tried to evolve family medicine discipline specialty in India. So thank you all. Thank you, Sankha, for letting me speak on behalf of Academy of Family Physicians of India and the work we have done. And this is the key message focused on evolving family medicine disciplines. Events and conferences are very, very important. Meeting the policy makers, which include the politicians, bureaucrats, the leaders of medical education is very important. Scientific publication is very important. As I said, we have published more than 400 papers. Now there must be around 600-700 papers focused on family medicine, which form the basis of policy shift in any country. And this is very, very important. Stakeholders, because we are part of the health system, we are not dominating the health system. So we have to get everybody agree the reforms that we are talking about. And we also have to take legal action. If it is possible, I talked that this is now an act. If it is not implemented, we can go to the Supreme Court of India. And earlier we rather went to Supreme Court, and there is, there's a legal process to readjust also. And legislative actions, I talked about inviting our health ministers, political leaders, vice president, as you saw. And the voice must reach to the highest level of the governance. And then only the change come. And it is finally, as I said, it is a continuous process. So what work we are doing, it is work in progress. But sooner or later, I expect in 5 to 10 years, we will be radically system in India. We have laid the sound foundation of it, and it is going to change the healthcare delivery system of India as well as
I think thank you, Raman. Thank you very much. What a remarkable journey.
So I'm done with my presentation.
Yeah, thanks. Yeah, we dropped you at the last minute. Thank you very much, Raman. So what a remarkable journey, starting in 2010 by establishing Academy of Family Physicians of India. And one highlight is that we can't avoid politicians, we can't avoid the bureaucrats. We have to work with them. That's what I saw throughout your presentation. And it's a great journey, I think, to establish and shape family medicine in India. Thank you very much, Raman. I hope that you could be able to stay with us. The connectivity
I'll try my best. I'm really sorry. My apologies for not with these network issues. I was traveling, and I'm very, very sorry for this network issue. Thank you, Sankha. Thank you all.
No worries. Yeah, you can switch off your video and just be with us. Thank you very much, Raman. So we listened to a great story in the national level. Now we are going to listen to a story which will tell us how the family medicine education in a country was started. So we have Professor Antoinette Perera with us from Sri Lanka. Professor Antoinette Perera is currently a Professor Emeritus of Family Medicine in University of Sri Jayewardenepura, Sri Lanka, and a Specialist Family Physician, Honorary Fellow of Royal College of General Practitioners, UK, and a Fellow of WONCA. And also she is a Fellow of College of General Practitioners of Sri Lanka and a past president. And interestingly, she is member of College of Dermatologists from inception to date, and she's the only consultant dermatologist in the Sri Lanka College of Dermatologists. Professor Antoinette Perera completed 50 years of clinical practice in 2022 and stopped face-to-face consultations since COVID-19, but still in phone practice and home visits. And she has experience of 22 years in health ministry in Sri Lanka, in primary care and secondary care, worked in district hospitals, base hospitals for nearly 8 years, and university family practice since 1997 to 2020. I think she still works as an honorary consultant there. Most importantly, she is my family medicine guru. So I'm honored to have her here today. Professor Antoinette, over to you.
I have to share the screen.
Yeah, yes, ma'am.
I just click on this, right?
You can share, yes. Yeah, great.
Is that all right? That's okay?
Yes, you can
you see?
share the slides now. Put the presentation mode. Good to go.
Oh, okay. Right? Is that right, Sankha?
Not yet, ma'am. Not yet. All right, fine.
Yeah. Go to the first slide. Right. So Sankha asked me to talk about policy and advocacy regarding putting up our Department of Family Medicine. But I have gone a little beyond that, and I'll talk to you about how we progressed over the years from nothing, as it were. Okay. So it was the College of General Practitioners of Sri Lanka who, it's a college launched by the Independent Medical Practitioners Association, which was association for all the general practitioners, specialists. It broke off and made the College of General Practitioners of Sri Lanka as the academic wing. So, and one of the main objectives was to train general practitioners in Sri Lanka, because Sri Lanka Medical Council allows after the MBBS for any of the doctors to practice in the community. So how they started was, they started with postgraduate training. Family medicine was introduced as a postgraduate diploma and MD when the local PGIM was established in 1979. And the then secretary of the college, Dr. Heen Nilame, was responsible for going and talking to the vice chancellor and getting family medicine into the PGIM. And they got the board of study launched by the College of General Practitioners, Sri Lanka. So once the board started, they advertised for the diploma. And that was mainly for private general practitioners. I was in the ministry, but there were lots of other doctors in the ministry who were interested in learning family medicine. So it was open actually, I think, to make up numbers to the Ministry of Health as well. So I was one of the early diplomates, and I graduated in 1984. Right, but there were some problems. And then I did the MD and became a board certified specialist in 94. Now, I must talk to you about the National Health Policy. According to the Sri Lankan National Health Policy, all citizens of Sri Lanka have access to free primary health care from any hospital, irrespective of where they live. So, so they can just walk into any hospital and they'll be treated. They have to be treated. Then, how this family medicine got into the undergraduate curriculum was, there was this President Premadasa, who was president in 89 to 94. He had this vision of training doctors to work in the community. So he had spoken to his personal physician, who was an eminent physician in the country, one Dr. Samarasinghe, that he wished to start a medical school at Jayewardenepura University. So then this Dr. Samarasinghe agreed to start one, and he started a curriculum committee. And he also had this idea that the medical students must learn the symptoms that patients come with at first contact. This is what actually Dr. Samarasinghe was my teacher at medical school. So I asked him why he thought of introducing family medicine. Then he said, where else can these students learn how these patients present with symptoms? So it was all hospital-based, our training before that. So then to introduce family medicine into the curriculum, they called Dr. Leela D.A. Karunaratna, who was, what shall I say, who was attached to the private medical school that was run by the College of General Practitioners, and she was doing some work as in a family medicine unit. So here she was introduced. She was asked to come and give her expertise to introduce family medicine into the curriculum. So this is a very old photograph. This is how there was Professor Leela Karunaratna. She was taken as professor and chair of a department called Community Health, which had both community medicine and family medicine. And she was our first teacher. And there were no buildings. There was nothing. There was her officers, what shall I say, accommodated in a graduate studies building, a small place. And this is the first batch of, some of them are here. And this is Professor Karunaratna, who started in 1993. She was the one and only teacher for some time. So in 1993, for the first time, family medicine was introduced as a subject in any university in Sri Lanka. So now Dr. Samarasinghe had this vision of introducing first contact care, and the university, the curriculum committee accepted this as a policy. Then, so as I said, Leela was prof and chair of Department of Community Health. 95, I joined, and the department was renamed as Community Medicine and Family Medicine. Right now, how to introduce? Now the problem is there is no family medicine in any of the curricula in the medical schools in the country. So to accommodate an extra subject is no easy thing, because the time allocation has to be the same. All faculties hold their final exams at one and the same time, and the students have to go out, and you don't extend the time in any program. So what was done was, she designed a curriculum which went over all 5 years from year one, taking time from various other disciplines. And then the professor, the clinical appointment was a 4-week appointment, we had an appointment where we were taught OP. We were sent to the outpatients department of the biggest hospital in the country to learn whatever the OPD medicine and surgery it was called, but it was all secondary level people who taught us, and it was all secondary level medicine. So there was a time allocation of 4 weeks. So that was only taken to share the professor what shall I say, to convert the 4-week appointment for our family medicine appointment. And we shared a professorial appointment with psychiatry, which also had 4 weeks. So this in the early stages, there had to be a lot of advocacy, talking to the curriculum committees, to the other specialists to get all these things done. So Leela was the one who actually did all those things. Then in 96, Leela retired and I was left to continue. But she worked on a contract basis till 2000 and then helped me along. So the department was later changed into Department of Community Medicine and Family Medicine. Now, just to tell you about community medicine, Sri Lanka has a very strong grassroots level public health system, primary healthcare system, where there is a health worker which goes to the houses. So, and that health unit system was started in 1929. And now it's an island-wide strong system with the country divided into MOH, the medical officer of health areas, where they concentrate on public health, that is preventive medicine at population level. So community medicine is a subject which was established in the country in the universities. Then, so we became part of that. Now, the department was called Community Health. A family medicine professor chaired the department. And then, of course, the community medicine people were recruited. And there were lots of, disagreements and various things. Anyway, then, now we had to have 4 weeks family medicine appointment, clinical training. And the final year, students will come after 5 years. So we had to have some training practice. So we decided to start a practice center. And talking to the main university vice chancellors, all the advocacy was done with the vice chancellors and the administrators in the university, and of course the rest of the faculty. Now this is a new faculty, so they supported us in various ways. So we got a piece of land with access to university premises. We were lucky; the university gave us that. Then we, the dean of our faculty at that time was one Professor Jeffrey, who got the JICA grant. And the JICA, when they heard about our teaching of family medicine, they promised to equip the center if we had the building in a period of whatever, 1 year or whatever. So Leela was very enthusiastic and she even drew the plan for a small center. That is how it went on. Then, so now Jayewardenepura had family medicine. Then Kelaniya also the next year started family medicine, and they had the program up to the 4th year only. We went on till the final year. So then the University Family Practice Center built, and we opened it to the public in 97. we both of us were there and only one laborer. We had no cadre for various staff because the major discipline was community medicine. Anyway, with all that, we had 1,000 families registered by 2000, and we had the College of General Practitioners whose offered their support to help us in training the medical students. And a group of general practitioners, they actually volunteered, and we took them as extended faculty, and they worked without any remuneration at first. And we had the center ready for training by 1998 for the first batch. This is the foundation stone laying by the Vice Chancellor. Then this is Professor Jeffrey at the opening ceremony. See, the Ministry of Health people, the college, everybody came for the opening ceremony. The Professor Jeffrey is no more, but he was the one who gave me a lot of support at the beginning. Then, just imagine what it was like. No staff, have to build up a practice, students coming for teaching. And anyway, we were lucky because we had a very good extended faculty member system of GPs who took in our students, and the GPs are trained as to how they should, teach the medical students, what they should teach the medical students. And so it went on like that. But it was, it was very a matter of long hours and very hard work to improve services. But what happened was we had to, anyway, now it's talking about policy and advocacy. As a policy, you start family medicine in the curriculum, but to get it going with few people, we had to have a lot of, we had to work very hard. So we had to build relationships. First, what I did was had a relationship with the teaching hospital. There were two teaching hospitals, one at Kalboila, the other one at Jayewardenepura. And we were only working during the weekdays, Monday to Friday, and Saturday and Sunday. And in the evenings, our patients had to be, looked after if anything happened. So the professorial units, which also were started by 1998, they lent their support, and our patients went directly to those units if anything happened during the time we were not available. So we had to build relationships with all these different disciplines: medicine, surgery, geronobs, pediatrics, psychiatry. So then we had no card as such, because this was a mega department, and the card was the original card given in other universities to the community medicine. So then we had to speak to vice chancellors, registrars, and they helped by transferring the cadres from free places in the rest of the university to our center as such. So that is how we managed in the early days. The head of the department, now Leela retired, head of the department was one Professor Sivayogan, who was a community medicine specialist. He was a real good friend, and he supported me and allowed me to run our program without any interference from him. And the Professor of Pediatrics and Professor of Medicine, they came and conducted referrals in the evenings at our center. So it was all, I mean, all that helped to build our practice. Now now we started with this gentleman only, and myself and Leela. Then after that we got this is a medical student who graduated with MBBS, and we had what you called demonstrators for about an year because they had to wait for their internship. This gentleman is now a professor of anatomy in another university. And then we recruited a nursing sister retired from the hospital, and another lady from some other place we were given to do our day-to-day cleaning and various other things. And these two were just on contract to do typing and various things. And this is Miss Amita Jayewardenepura, who was one of the very good non-academic members who did a lot of work to bring up our services. She was interested in laboratory technology, so we sent her for Emeritus training, and she's a qualified technologist now. So it was really building good relationships with the rest of the faculty, and all of them helped us in the early stages. Physiology department did full blood counts and ESRs. Biochemistry did blood sugars. Microbiology did some cultures. Like that, they helped us to expand our services to the public. Then, of course, this went on. After 2000, we had a senior lecturer and a junior lecturer joining us, which helped us enormously. And we had a large clientele from the community. And then the family medicine program was, appreciated by the faculty and by the students. At first, we had no proper assessment. We had one question in the surgery paper, and one question in the GNOPS paper, and one question in the pediatrics paper, SCQs. And the professor of pediatrics was very supportive, and he gave us another 3 marks to conduct an OSCE at the end of the year. So that is how we assessed our students. So then the faculty realized that this won't do, and we gave us a separate assessment, but assessment which had to be shared with psychiatry. So that was what we were doing. Now we have a separate assessment for family medicine. After so many years, we have been able to get that done. Then community medicine was a department of public health from the start. The first health unit was established in 1929. They were very advanced, and they found it very difficult to have us with our teaching on person-centered curative medicine. And they were very advanced, and they used to get a lot of resources. Then the cadre, so it was like difficult to it was difficult to share everything with us. And there were lots of problems, and then ultimately we thought we better break off and form a new department. Getting a new department from the UGC is not an easy thing. But the new professor in charge of the mega department, she also wanted to break off from us. So we wrote the proposal. We got it through, we had to get it through various boards. So faculty board, then Senate, and the UGC. I was told when I started, I'll have to wait for 14 years at least to get a department. But we got it in 3 years. So we got a department and it was ceremonially opened in May 2004. So this was the dean at the time who opened the center, and this was the staff at that time. These two youngsters were demonstrators. They are both specialists now. And this is myself and Dr. Shamali, who is now the professor. This is Professor Sivayogan, and this was our peon-like person. This lady didn't actually belong to the department. So, and this was the original, for the very first building we had. And the first batch of students, when they graduated, one of the batch was a sculptor. He gave us this sculpture. We have it to this day, which depicts a family. So it was how it was done. I mean, within a few years, say 2004, we had a department. And it was all lot of teamwork and giving leadership with humility, without fighting, and asking for a lot of things, and also working hard with long hours. I had to work from 7:30 in the morning to maybe 5:36 in the evening. And this Shamali, who is now the professor, she was like a shadow, and she did most of the computer typing, and then she also helped me. So we worked very hard. And the non-academic team also, there are only few, so they also supported very much. And so we sent this girl for MLT training. We set up a lab, and the friends from my hospital days came to my rescue and helped me to set up a laboratory. And so it was all, teamwork and getting help from others and having a commitment to the project of somehow getting family medicine through. So, and communication with peers and staff and the admin in the university, and building relationships with patients. So we started visiting patients at home, then sending patients to elders' homes in the community, and we also built good relationship with the community. So much of goodwill we got ultimately. The university was happy, as before we started, there were clashes between the villagers and the students, not medical students. This is a university, there were lots of other departments. And once we started this, our center, and the villagers were treated, and the clashes stopped. And when we entered, the university closes every 1 month or so. Then these closures stopped after we started our center. So the university senate and university vice chancellor and the team supported us. So over the years, now we had no buildings, nothing, but over the years, the deans got funds, and the various buildings were built. And all the departments had space within a common area. Only we were left in the same old place because the dean was not very happy to shift us from the old center to the new faculty area. Anyway, while we were, pondering on this and how to get over this problem, the university circulated a township grant, and our university won the township grant over the other universities because of the work done by us to the community. And we were awarded a large sum to have this present building, which has 3 stories or 4 stories. And then so we progressed like that. Then the students also got very enthusiastic. Some students selecting family medicine as a career. And then the postgraduate training also went in par, and and the students, the PG students who graduated with the MD, then started units in different parts of the country. And there are now primary care units run by different medical faculties, where one of our postgraduates has, been able to start a department of community medicine and family medicine in their medical faculties. And we have Jaffna, Batiklo, Gaul, Colombo, Ragama, all of them have centers. But this Jaffna one, where the now others built the training centers like us, but this Dr. Kumaran is one of our postgrads who managed to get a hospital, small hospital from the ministry, which he turned into a primary care, family medicine training center. And he has a special training where he does it with the community medicine, the public health people. We of course run on our own. The public health people run on their own. They do preventive medicine for populations. We do primary care for for people. So now these people, their program is where patients go first to the community medicine, the staff, and then they refer to family medicine, and family medicine, when they need referral, go to the hospital. So, and the service to the community is really exceptional, and it is run mainly with volunteers. So, family medicine, just became very, very popular, and we advanced over a few years to a stage which I think you can't sort of dream of. So then we had to have advocacy of the policymakers. So because the people in the Ministry of Health, and the Ministry of Health also mainly with specialists from community medicine. So introducing family medicine into the system was not a very easy thing. So, but I was invited to a consultative committee where they were discussing, thinking about introducing a family medicine system. So, but still it has not happened. But primary care is being strengthened in different ways. We have a new government, so let's hope they have promised to improve primary care, and we have a large number of primary care hospitals. I think about 500 hospitals in the country are primary level hospitals, but they are not equipped. They are not properly equipped, nor are they trained doctors. So that's a problem. So this was an advocacy, not a post as such. It was an advocacy, what shall I say, leaflet done by the Ministry of Health. For then Minister of Health, one Mrs. Sirisena, who was later on our president. This was done during his time to, to introduce the family doctor system. This I found in my documents, with my documents, so I thought I'll put it. So this was in, I think, before 2000, somewhere in 2018 or 19. So, and a shared care cluster was proposed by the ministry. That is to have small hospitals draining into a large hospital where there are specialists. So first, there's all citizens have a hospital to go to, and there's a hospital within 3 kilometers of a person's residence all over the country. So that was that was there. So they were trying to ministry was trying to the policy planning ministry was trying to do that at one time, but it has still not progressed. And then we also had a lot of support from various people. WONCA has been supporting us over the years, and the examiners came from Australia, UK for our postgraduate exams, and they took in our PGs for training. So all that support we had. Now, of course, we have Sankha, who is trying to carry family medicine forward. So when I look back, so we had a lot of problems, and we were not successful all the time. But we also had happiness of seeing patients smile, mending broken family relationships, standing with them in those patients still come to me after more than 25 years. Then their children grew up, and then they also have children. So the practice is like it's a continuity of care practice. So it's going on. But since COVID, I think the services got broken up. Some of the trained doctors left for Australia with this economic crisis. So it has to be again rebuilt. Then, so it's 40 years since I chose family medicine as a career. And I have never sort of looked back or thought that I had made a mistake. So I thought of giving a tribute to all. Many people were responsible for bringing family medicine forward to this level. I can't name them all, right? All the deans of our faculty over the years, academics of all the departments, the college teachers and the councils, then the planning division of the Ministry of Health, especially Dr. Susi Perera, Director Planning and Development in the early stages, still advocate in the ministry. And now our students who are specialists in different fields, some are professors, others working in family care, primary care. So they are the people who make all this possible. I have put Professor Leela's picture because she's the one who originally managed to introduce family medicine as a subject. But it's the help of so many people, College of General Practitioners, Ministry of Health, which all made it possible, and the faculty, all the departments in the faculty, which made it all possible for us to, now actually we have a separate assessment also, made it all possible to bring family medicine forward. And the postgraduate training went on, and now we have many postgraduates. Ministry was not releasing doctors to do the postgraduate training for MD, but since 2008, we managed to get that done. So as a policy, they accepted family medicine trainees from the ministry to be released. First, they released only 3, now they release 15. So it was all a matter of going and talking to people. It was not I who did it alone. It was over the years, others took it over, and they have also, done a lot of advocacy in the ministry to get all these postgraduate training programs on board. So, no, I'm not going to play that national anthem. There was a nice anthem done by instruments, but it can't be played. It's a video. So Sankha, I don't know whether this met the requirements you had in mind. So I stop now.
Thank you, Professor Antoinette, for your wonderful talk on how family medicine progressed in Sri Lanka. The materials you covered was engaging as it was thoughtful, and we are so grateful that you shared your expertise, experience, and journey. It's a great example of influencing local level policymakers by working collaboratively in advocating to stabilize the first family medicine department in Sri Lanka and building positive professional relationships in getting community support and involvement. Thank you very much, Professor Antoinette, for your wonderful presentation. Now I am going to invite our next speaker, who is Professor Waris Qidwai. He is Professor of Family Medicine at Aga Khan University in Karachi, Pakistan, and he is affiliated with the university for past 39 years. He has published more than 200 research papers. He is former chairman, Family Medicine Department, Aga Khan University, Karachi, Pakistan. He has 6 fellowships, including from WONCA also, and he was former chairman of WONCA Working Party of Research. So, Professor Waris Qidwai, it's over to you.
Hello, good morning, friends. Good afternoon, friends. This is Dr. Waris from Pakistan. I'm going to talk about our experience of getting recognition for family medicine education in Pakistan through our advocacy, and I'm going to share our experience. Family medicine has remained a neglected discipline in Pakistan, and this is despite the fact that majority of the healthcare services are provided by family physicians in the country. So therefore, we felt the need that we should go to the Pakistan Medical and Dental Council that regulates medical education in the country. We go to them and then we put our case across that they should give proper recognition to family medicine education in the MBBS medical curriculum. For this, we felt the need to unite all the stakeholders in the country. So after we recognized the need to convince the Pakistan Medical and Dental Council to give due share to family medicine education in the undergraduate medical education curriculum in the country, after we felt the need for this, we then went across and we tried to unite all the family medicine stakeholders in the country so that we can stand on one platform and we can put our voice across as a unified voice. So our objective was basically to convince the Pakistan Medical and Dental Council that family medicine should be accepted as a specialty in the country. And we united all the stakeholders on one platform before we went and we placed our case before the Pakistan Medical and Dental Council. Now the stakeholders in Pakistan are several. There are family practice organizations in the country, and then there are academic institutions with family medicine programs in the country. So we brought all of them together under one umbrella on one platform, and then we convinced ourselves that there is a need that we should go and talk to the Pakistan Medical and Dental Council in Islamabad and argue with them that family medicine is important in the country and it is not getting its due recognition. We are providing healthcare services to majority of the population. So unless until Pakistan Medical and Dental Council gives recognition to education of family medicine at the undergraduate level, we will not be able to provide good healthcare to the people of the country. Now this is a photograph that is taken in Lahore, where we had a breakfast meeting, and before we decided to go and meet the Pakistan Medical and Dental Council. All the major stakeholders, a majority of the stakeholders in the country are in this photograph. after meeting and coming together as one group, we took appointment with the senior officials from the Pakistan Medical and Dental Council, and we went there and we had a meeting with them, and we placed our case for education of family medicine at undergraduate level in the country. And basically what happened was that we had a very fruitful meeting, and we were able to convince the senior members of the Pakistan Medical and Dental Council that there is a need to give proper place to family medicine teaching at the undergraduate level in the medical colleges in the country. And once we were able to convince them, then our success story is that Pakistan Medical and Dental Council made it mandatory for all medical colleges in the country to have family medicine departments, also to have protected time and a paper in family medicine in final year in the undergraduate MBBS program. So we were able to achieve our goal, and we were able to achieve it through getting united together and then putting our case across the regulatory organization in the country, and then able to convince them for the need, and then eventually we were able to get recognition for family medicine in the undergraduate curriculum across the country. So basically we have achieved our target. As a conclusion, I will just repeat the same what I have already said, that we were able to convince the Pakistan Medical and Dental Council there is a need to give proper recognition and place to undergraduate family medicine education in the medical colleges across the country. So we were able to convince them, and the convince them was possible by coming together of all the stakeholders in the country, and also making the council realize that majority of the healthcare services in the country are provided by family physicians. So unless until there is a place for them in the undergraduate education curriculum, the outcome will not be good for the health of the people of the country. So we were able to put across our case, and we were able to get success through notification from the council that there will be mandatory departments in each medical college in family medicine, and then also there will be protected time for teaching of family medicine at the undergraduate level, and there will be a separate paper of family medicine in the final year of the curriculum. So we were able to get this successful outcome through our planned effort. This is our Khan University where I've been working for the last almost 39 years. Thank you for your attentive listening.
Thank you, Professor Waris. I know that one reason for your short presentation was the anticipated internet issue in the country due to some protests and issues happening currently. Anyway, thank you very much for joining us, and for this great sharing this great journey with us. Thank you very much. I think that is again proving the same point what we were reiterating in the previous talks, the importance of policy advocacy in different levels, the national levels, the regional level and local level, and different ways. The methods, the techniques could be different, but again, as a pioneer in family medicine education in Pakistan, we really appreciate your journey and efforts, and thank you for sharing that. We will now move to the question and answer session. I saw some questions as well as requests for questions. So are there any questions?
Yes.
Yeah, you can.
I'm okay to ask a question. Just a comment about the internet first. I'm actually based closer to where the protests are, but my internet, touch wood, is working fine, which is good. The other comment was With regards to Professor Waris Qidwai's presentation, excellent presentation by all three presenters, and thank you very much for sharing the journey. But I was just wondering, Professor Qidwai, there has been reforms after 2014 in a lot of way, in the academic side of primary care, in the undergrad, postgraduate trainings of primary care, and in the administrative side, the clinical side as well. From 2014 onwards, I didn't see many slides relating to that. Was there any reason why?
Actually, if I talk about the whole journey, then it would take 1 hour. Like, I was asked to make my presentation, a short presentation, about 15 minutes. So that's why I have not mentioned that as a result of this regulatory change that has happened, we have now medical colleges with departments of family medicine. So that is one of the things that has happened. Then there are now MRCGP International has also started working in our country. So a lot of education programs are happening in that direction. So I didn't touch upon a lot of things on purpose. I just wanted to make a point that if you want to bring a policy change, you have to talk to the regulatory body and you have to talk in one voice. You have to bring all those stakeholders together. This was almost 10 years of work that resulted in that regulatory notification that came out from the Pakistan Medical and Dental Council.
Sure. There has been a diploma in family medicine, a one-year bridging program, which is being offered in 9 countries across the country. And yes, policy advocacy has been happening a lot at the provincial level. I can talk about Punjab and Islamabad Capital Territory and the KP as well. Yes, a lot of boundaries have been pushed and advocacy has taken place, and also through print media with regular newspaper columns. Thank you very much. I just wanted to add that.
Thank you, Hina. I think, what Professor Waris and his colleagues started, now it's in your hands as the academics and the pioneers in, the main people in family medicine in Pakistan now. Professor Waris, I have a question from you about the journey. What were the challenges you had in the initial phase of this process?
I think the biggest challenge that we faced was to bring all people together on one platform. That was our biggest challenge, because there are more than a dozen stakeholders, organizations in the country, and so it was not easy to bring them all on to the same platform. But when we decided that we will go to the regulatory body and try to talk for regulation, then that point brought everybody together on one platform. So that was our biggest challenge. The second biggest challenge is that we don't have much lobbying, much support in the regulatory body, because in the regulatory body, most of the people there are subspecialists from other specialties, and we don't have family doctors there representing our interests. So to convince them and to talk to them was not that simple. So I mean, it took a lot of effort, but we were able to get that regulation through, and as a result, now we have medical colleges. It's mandatory to have family medicine department. We don't have enough faculty for more than 100 medical colleges to have the department, but it's a long journey. We have just started, and we have a long way to go.
Thank you. Pramen, do you have any questions here?
No, it's fine. I think, is Raman is joining?
Raman told, I just contacted him and he told he will join in. So Sen, do you have any questions? I saw that you have told something initially, but probably was the question from Raman, or do you have any other question from the other speakers? Hi. Yeah, you're muted.
Hello, everybody. Thank you for your presentations. It was very interesting to hear. I just wanted your opinions, considering I I live in a place where family medicine has been part of the, shall we say, part of medicine as a subject for a long time. That hasn't been the problem, but the issue is, how do you get politics and politicians more interested in it and understanding that it's something that can save money in terms of healthcare at the end rather than spend it. I'm quoting an old WONCA president when I say Richard Rich had said, if you put one extra surgeon per 100 people in the population, the mortality increases. If you put one GP per 100 people in the population, mortality sinks. And preventive medicine, for example, is simply not paid for by our healthcare system. It's actually not in our law. Raman spoke about things having to be policy and law, and hello, Raman. Things having to be policy and law and actually embedded in it. And also Dr. Perera mentioned that that's important, having it embedded into actually in your legislation. Otherwise, if you want to hold anybody accountable, they just sort of say, yeah, well, it doesn't matter, and sort of turn around and wish you away. So any answers from any of the speakers? What's their suggestions for trying to get things, well, I suppose I'd say more solidly embedded into the actual legislation? Who do you talk to? Who do you attack?
I can answer that.
Raman, would you like to go first? Sorry, Hina, do you have any additions?
I can respond to that question after Raman.
Yeah, sure. After the speakers, yes, I welcome. Raman, you can go first, and probably Prasad.
So I think we have to engage with two group of people. One, the political leaderships, and then the bureaucrats. I'm not sure how it works in different democracies or governments, but in our country, bureaucracy is continuous. Irrespective of which political party is in the power. So there is a continuous process of policy development and implementation, which the bureaucracy take care of. And also, when there is new initiative, it has to come through the political system, which is in power. So we have to engage both of them simultaneously, and we have to keep on, pushing for both. Technically, I mean, you write technical policy drafts or technical papers, which are useful for policymakers. Just saying things that in vague and broad terms doesn't matter, and we have to evolve it from where it is. Like as I talked about the previous national health policies of India, previous reports of Government of India. And we were always saying that we want implementation of these documents or this policy, which are the declaration of government itself. We did not say that it is our demand. I was saying that what is already in the policy of yours, we are asking to implement for it. So this is our approach is like. And then the other angle is, in the legislative process, you have to create a democratic demand, which is to come from the community. And the community leaders are again the politicians, the senators, member of parliaments. And if they raise your voice, that comes into the legislative cycle or process. And then unless it is addressed, it is not resolved. As individuals, if we write to them, meet them, or say something, it doesn't matter, in long term. So this is my suggestion.
Thanks a lot, because we do live I live in a democracy, I live in Switzerland, but the problem is people don't seem to understand what the decisions that have been made implement for their health on a long-term basis. There's a lot of things that they just haven't understood. We are in a system where we have 25, 30 different medical insurances instead of having a single insurance. And there's hundreds of countries around the world that function just fine on a single insurance system and private separately, if they wish. And they don't understand the benefits of it. And our insurance policies, what you pay for it is simply going up, up, up. The population is basically impovering itself. We're getting to the stage where there's a gap that's turning up between the super rich and everybody else behind. Because at this point, there's some of it involves paying more than half of a person's salary just to have health insurance. And there's people who can't survive.
At your point, I think, but the best way is to prepare technical documents
proof.
which the gaps you are talking about
Mhm,
are articulated in written form.
mhm.
And then you present to the community through, it is important to engage community as well as the, policy makers, both. So policymakers need data, technical documents, and for public, for community, we need to run campaigns, which is in their own understanding and terms. I mean, they do not understand, we cannot say this. I mean, if they do not understand, it means we are not able to communicate properly. So we need to run campaigns which are easy to understand and they make a, informed choice decision.
Thank you, Raman. I think, Susan, great that we are having you here. I think we can learn from each other. There's nothing called that we are learning from high-income countries or we are learning from low-income countries. It's like we have these problems are more or less faced by someone in the world. So I think I'm sure that we can get some tips to handle our problems. And sometimes the systems are different. I understand. Something I can tell is that when you take Sri Lanka, even because I have much experience in Sri Lankan system, so the bureaucrats, that's the health ministry, the directors, the high officials are very important, sometimes than politicians, to implement the policies, because they are the main people who advise the politicians, because sometimes politicians do not touch feel like health because they are not much comprehensive, or they are not much aware or educated about that. So sometimes the bureaucrats mostly important, and we have seen that many of the family medicine doctors are not involved in policy making or policy decision making places like in the ministry. I think this is not just something happening only in low and middle income countries, but I have seen it even in the USA. When I had a chat with one of our previous North American presidents, the WONCA presidents, he told the same thing is happening in the USA as well. The people in the government or the ministries are more or less not family medicine doctors, most of the time public health or community medicine people. And the funds are also distributed in a very, you understand, in a not in a real way of which has equity. One good thing is like politicians like stories. So for most of the time, stories would help to get down politicians. And what Raman had done always, inviting them to the conferences and giving them a warm welcome, and then the next step would be having a policy document out after the conference. I think that is a great strategy. I have seen that. I have witnessed that in 2017. Is that 18? I can't remember. The Rural Health Conference happened in New Delhi. Professor Antoinette, do you have anything to add?
Yeah, I would like to say something. Now, our country is a tiny island compared to the other big countries, especially India, right? So, in our case, we should really find it easy to, implement this system. In actual fact, we were asked to do a study. Sankha, you were involved in it, premises study, primary care systems and performance in a middle income country. So in that study, I had to go and speak to the Minister of Health, who was a dental surgeon, really. So he understood the problems and he promised to, start a family doctor system. That is what he did promise. That was in 2016-17. It's published and it's in the WHO website also. But then the governments changed and the ministers have changed, and these things don't happen. But now we have some hope. The present Minister of Health is one of our students. Sankha, you know him?
He's one of our senior colleagues, yeah.
Yes. So one of our students, and the new government has promised to strengthen primary care. But it's happening in our country in different ways, isn't it, Sankha? Various projects are being carried out. But as a country as a whole, so far, nothing has happened to have, to have this system in place. Various things are happening. As someone said, it's the ministry bureaucrats who organize all these, documents, everything. The ministers are just, they are unaware in the first place, some of them, and some of them are not really interested. So, but if
but that you're right in saying that you have to have the policy and the bureaucrats behind it. But the problem is, it's not because one is small that things go faster. Switzerland is not very much bigger than Sri Lanka, or Sri Lanka bigger than us. Small island, small country, we have some similarities there.
Yeah.
And the second part of it is, I mean, we have things to learn from countries like India or other big countries in Asia where things do function differently, but where you simply have a different way of making things go through in terms of policy. Because for us, it's not just the fact that the government changes and then everything else changes behind it. The government can change, as Raman was saying, the policies stay because some of it is either written into constitution or written into laws that they can't move, and they can't just change as and how they like. The problem is what you're saying, Sankha. If you have a Congress or anything like that, and you can get them to come, we've had situations where we've invited all the different players, the stakeholders involved, and there's some who don't bloody show up, sorry for the French, because they're not interested in losing their leverage. They're not interested in losing the money behind what they do. The fact that we can't choose how and what happens with things like tobacco use or alcohol use or sugar. Recently, in one of our young doctors groups, there was a colleague from, I can't remember what country, who started a discussion, what is in Coca-Cola, the world around, and got everybody to send a picture of just the ingredients on a Coca-Cola bottle. And it's not the same everywhere. And in some countries, it's legislated to say you can't just sell this sugary crap to everyone as and how you want, and others not. If somebody said,
can I answer that question?
No sweet drinks,
Yes.
it's not going to happen.
Yeah, I would like to respond to Suzanne. There are two examples I'm going to mention responding to the answer. The government changes and the other bureaucracy and technocrats do not change. I'll quote two examples here. The universal health coverage, which was Health for All package that came somewhere in 2018, and we worked tirelessly for it across the country. And we had to, when the government changed, everything changed because we are supplied by the donors, which are based outside our countries. The other example, I established a primary care outpatients in a secondary care hospital in a public sector facility, right? Which may have happened for the very first time in the northern part of Punjab. We ran the clinic successfully for a year. It was serving a population which was not too educated and low socioeconomic. We managed to reduce the persistently high HbA1c from 12%, sorry, we measure it in percentage, the HbA1c rather than millimoles per moles in other countries, down to around 8-9% through education and dietitian. Government changed, my clinic was closed. So here, the trickle-down effect from hierarchy to top is different. We don't believe in bottom-up approach. We believe in top-down approach. So that's the culture of this area, maybe.
Thank you. Thank you, Hina. Professor Waris, do you have anything to add?
Yes, I hope you can hear me because I have problems, with the connectivity. Basically, I would like to point out something which I found something very, very important in my discourse as a family doctor. When I talk of primary care, I don't talk just of primary care. Whenever I talk to people, I talk about strengthening of the health system, which means the primary health care, secondary care, tertiary care, and quaternary care. And I talk about functional health system. I don't talk of just because when you go and you talk to the resident about primary care, then the thing is that they are less receptive. But when you go and you talk to them about strengthening the health system in the country, making it operational, that patients go through the system flawlessly from primary care up to the tertiary care and come back. So that is one of the approach that we can take. That I found very useful. People are more receptive when we talk of that.
Yes, thank you for those thoughts. Do you have any other questions? Yes.
I commented that we need good mentoring and leadership skills in primary care and have access to power corridors to be able to take the counter arguments that are shared with us, and we have to come into a position where we are able to respond and defend. Thank you.
Yes, I agree. I know that the situation in the region is different, a bit different from where Susan is. I mean, but Susan, on the other hand, the politicians are politicians wherever it is. That's understood. What I understood from what you told as well. Anyway, so thank you very much. There are no other questions. We can call it a day. I am much grateful to all three speakers, Professor Antoinette Perera, Professor Waris Qidwai, and Dr. Raman Kumar for sharing their enormous experience and the journey, which is very much important. I think this is the most important thing I thought, because these things are sharing your experience is very important to juniors and your followers and your students, because it always inspire the others and sometimes give solutions and tips to their journeys as well. So thank you for sharing that in different levels, in national level, regional level, in academic level, how you acted in the means of policy advocacy, advocated the politicians, the bureaucrats, the academic heads, etc., to get down family medicine to the status which is now there in your country. So thank you very much for you all, and all also to my colleagues who joined today and being with us for 2 hours almost. So thanks very much. Great webinar.
Thank you,
And see you again.
Thank you.
Thank you very much.